Hi, everyone. It's so nice to see all of your faces or your names. I'm really excited to have Walt Fritz with us tonight. Since I became the program chair, I've had a fantasy that he would come and present, so it's very exciting. Many of us have taken his course and it's been transformative. So I won't spend much time introducing him, but I'll pass the mic over to Walt and just say thank you so much for volunteering your time and expertise. And if anyone wants to know more after this talk, please take his course. It is
Oh,
truly a transformative experience, both personally and for your work.
thank you. That's a good introduction. I don't need to say anything then, do I? Thanks for having me. I'm really honored to be here. I'm Walt Fritz, physical therapist from New York State. I got into this field, if you will, by an invitation from Jan Potter Reed back in 2012 to teach a one of class in Chicago in 2013. That it was fairly well attended for a class like that, and I thought went horribly, but people seemed to enjoy the approach. I got invited because I have a big mouth and I was spouting off on the internet about something or other when I was treating neck pain and happened upon an area in through here behind the larynx, where I would treat neck pain, but they were people were telling me things that were not really within my PT domain, voice issues, swallowing issues, that sort of thing. Hang on one second. They're telling me I'm speaking Turkish. I probably want to change that, right? Sorry. There we go. Okay. I never had that come up before, and I never got accused of speaking Turkish. So there you go. But anyway, I was invited to that class along with Ben Asher, the ENT from New York City, to teach this one of class, and I really enjoyed it. I knew very little about the field. Um, I had a few speech pathologists in my earlier classes, but nothing that would really tell me that this is what I want to do. But it really intrigued me. So over the next couple of years from that point, I just, along with some help from Jan Potter, Barbara Wilson, and a few others, they really helped me sort of craft my curriculum to begin meeting the needs of the speech pathologists and voice professionals. And I guess the rest is history from there, because it's just been really what I do now in terms of the educational component of what I do as a professional. It was longer than 30 seconds. Sorry, Hillary.
No, that's perfect.
Yeah,
That it's wonderful to hear a little bit about your past and how you got to where you are today. I forgot
yeah.
to mention that really this conversation is, or this presentation is a conversation, and that includes all of you in the audience. So if you have questions that come up, I'm going to lead some questions, but if some things come up, please put it into the chat, and a couple of our board members are moderating that chat, but we really appreciate any of your input. Um,
Yes, I'll be moderating the chat. So
okay,
if anything comes up, I will politely interject.
so
Yeah, and I can see them too. So there's certainly sorry.
no good.
I I I love people who challenge me. I love people who question me, because that's how I got to where I am today, with starting to question the things that I learned as a physical therapist and manual therapist, and not really agreeing with a lot of it. And it's still what I'm doing now. So if you want to throw spitballs at me through chat, go ahead, please do it.
I love that invitation.
Yeah,
I'm
yeah.
excited to see what comes up.
Okay.
So, I know from our poll that sort of worked but didn't work. A lot of us here are speech pathologists or laryngologists, and we're all pretty familiar with the idea of laryngeal manual therapy. But I know there's a lot of terms that kind of are around that, whether it's laryngeal massage or myofascial release and things. And could you just explain to us, so we're all on the same page, what is laryngeal manual therapy and how is it used in treating voice disorders?
Well, the first part of the question, what is laryngeal manual therapy, is actually a difficult one to answer, and it's an easy one to answer. If we're using touch to impact voice in this area, I would call it laryngeal manual therapy. Whereas people like to compartmentalize or sort of tribalize it into more aggressive type work, or with the muscle, with the fascia, with the trigger point, massage, manual therapy, there's all certain phrases. And when you start going into the literature, there's really not a good clear cut way to distinguish, well, how is one of them different than another? And that certainly gets people interested because there's all these different studies. One might show laryngeal manual therapy does this, another one might say laryngeal myofascial release does that. But I think the reality is we're all doing incredibly similar things when it comes to touch, despite what we think we're touching or impacting and what we think we're changing. We're only touching a person's skin, and everything else is a
Is
bit
it
of a
gonna
guess as you move deeper. What's that?
it's gonna rub his scar?
Well, I
Oh,
think
okay.
I
I guess
think we're
that's up.
getting some feedback from, or
Something about rubbing a scar. Yeah.
uh, just could everyone make sure they're muted? All right.
So, especially for the past 6 or 7 years, one of my biggest issues was really questioning: Are we really doing what we think we're doing, and are we really affecting people the way we think we're affecting people? And in terms of laryngeal manual therapy, it's literally just using touch, using pressure, using stretch, using massage to try and normalize the voice.
So, and historically, what you're saying is that like myofascial really thought that you were like manipulating the muscles and things like that. But what you're kind of, could you explain a little bit about how your approach to manual therapy
Yeah.
maybe
So
differs?
myofascial release, even though myo is the muscle, myofascial release was always about that. No, it's not the muscle, it's the fascia, the connective tissue that surrounds it, was seen to be what was at fault, and that we somehow could use a specific form of touch to impact that fascia restriction. But people speak the same thing about muscle tension, that if we do more aggressive manipulations and reposturing, we're able to locally reduce that muscle tone, muscle tension, and allow a more normalized voice. I I use combinations of all of those approaches, but I don't feel that I'm saying, okay, right now we're going to work on a trigger point. This time we're going to work on the cartilage. This time we're going to work on the muscle. I mean, we're literally working on a human being versus all the camps that people slice manual therapy up into to say, no, 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 I'm working on all of the weakness or the whatever that might be. And I think I have a more um, maybe a holistic approach, maybe call it generic approach, that we're working with a human being. And as soon as we open the lens beyond just the tissues that we think we're impacting, we can see there's a lot more to this than just what we're doing right here. Knowing more about that also gives us more opportunity to possibly impact the individual. To me, it's like the progression. I'm kind of going right into the historical milestones, if you don't mind, Hillary.
Perfect.
Frequently cited is Aronson 1990, clinical voice disorders. It's the one. It's the book, the reference cited in Nelson Roy's early work, and a lot of the works through the 1990s and 2000s, which kind of puzzles me because Arnold Aronson wrote the same book. He wrote the original book back in 1980, and literally it's the same chapter from 1980. So the reference to me goes back to 1980 when Aronson introduced using laryngeal type. The phrasing wasn't quite what it is now, but using manual therapy to help with hyperfunctional voice, with voice disorders. It wasn't until 1993 that I believe that Nelson Roy was the first one to bring that into a study. And then certainly Nelson and Leslie Matheson and Jacob Lieberman, a lot of other folks, especially in the last 15 years, have been studying how the various forms of manual therapy can be impactful for, well, in this case, voice. And my particular interest is not just in voice, but it's swallowing, it's tongue function, it's oral motor, etc. Where are we there? What's controversial about laryngeal manual therapy? You asked, Hillary. I guess to some people it's not controversy at all. I guess the controversy is what style is most effective, right? How do we pick what is the perfect client for it? I just had a question on Facebook today. Somebody private messaged me and asked me about that. It's like, would this person be considered a candidate for manual therapy? And my brain doesn't think that way at all. And maybe because I'm a classic hammer and everybody that walks in my room is a nail. And I use manual therapy as my primary means of intervention with them. Not that we don't work with exercise and strengthening and all sorts of technique type things, but touch is my means of communication.
Mm.
So, when somebody says, well, how do you figure out what the best patient for touch-based interventions versus non-touch-based interventions. And sometimes to me, it's not until you touch them to see how they react to your touch will help determine if they might be amenable to that sort of intervention. I
Can
think
I
one of the
pop?
biggest problems,
Oh, go ahead.
one of the biggest problems is it's still viewed as therapy is remediating issues in the tissues, right? It's just one of those lines that people love. I've got issues in my tissues. It's whether it's muscle tension or whatever. And historically, that's how manual therapy was seen, that we're remediating it at the local level, at that peripheral level. When most of the modern literature is painting a much more complex, nuanced, and multifactorial perspective on how touch is impactful, not just for voice, but for all sorts of things. And again, I think as long as we stay in that issues in the tissues, we're going to be sort of stuck in the previous century. Part of my more general physical therapy community has begun to embrace some more up-to-date models, but honestly, I've not seen it happen anywhere as near as much in the laryngeal manual therapy literature.
I was just going to pop in it, well, and say, I think some of the controversy that I have encountered with manual therapies in general is it comes down to that issues in the tissues kind of idea of, you
Hmm.
know, we are doing something to someone to fix them in the speech pathology world. And what I
Yeah,
appreciate about your teaching is that it's not about we are doing something to you to fix that issue in the tissue. There is a partnership with the
yeah,
patient, and you take it to a higher level in your teaching of making the patient really a part of that experience. And one question that I got out of a course that I took with you that I ask all the time now is this useful to you? So
yeah,
that the
yeah.
patient is really engaged in that. And I think so from the SLP world, I think that that's where controversy comes in sometimes is we can't just do something to someone without bringing them into the process and expect there to be lasting benefit.
Absolutely. Yeah, unfortunately, it's so many people view not just manual therapy, but a lot of interventions as sort of clinician as observer instead of clinician as participant, because we really are. I quote a study in my classes about where they had a person just holding on to a patient's ankle and not doing anything, but just holding on. And what they were doing with the patient was they had their head monitored to try and figure out activation levels of the brain, et cetera. And what they found that there were two groups of clinicians, you might say. One of the clinicians had headphones on, and they were being blasted with loud noises under the assumption that they wouldn't be able to attend to their touch. The other group, the clinician wasn't wearing headphones. They could just think loving thoughts and touch the person's ankle. And what they were doing was observing what happened to the patient's basically the brain activation levels. And what they saw in the person who was touching them with headphones on was not much change. They really were just an observer because they weren't really participating because they weren't actually present in the engagement. Whereas in the other case where the clinician wasn't having headphones on, what they saw was this slow ramping up of the activation centers of the patient's brain. It basically said as long as the clinician is attending, is present, we use all sorts of kind of more esoteric words to describe that, grounding and all those things, but it's our presence that's appreciated, not just appreciated, but actually involves the patient to a greater extent. And I use that study to say, you know what, pay attention to what we're doing, be with them, and realize that sometimes the longer I touch them, the more those activation centers open up, because that peaked at 15 minutes, which I think was pretty interesting. When I say in my classes that I might hold a technique for 15 or 20 minutes, people look at me like, are you insane? How could you just do nothing like that for 15 or 20 minutes? But to me, it's allowing a process to unfold, whether I'm doing classical manipulation or just some slow, gentle holding. Maybe we're making changes right here at the tissue level. That actually is the hardest thing to prove when it comes to the current literature. But I know that as soon as I touch, as soon as I get permission with safe affective touch, that we open up a lot of pathways with interoceptive centers, autonomic centers, and just cognitive top up, bottom down type, or bottom up, top down type of approaches that really is how manual therapy is being seen now.
Well, I'm not sure if everybody is familiar, but when you say hold a position, so you mean you just, could you describe that a little more?
I can, yeah, because I think manual therapy, in terms of laryngeal manual therapy, is probably best classified by the more, I call it aggressive. I think it's probably a little bit more neutral to say it's more assertive laryngeal manipulation, where the therapy is the movement. The therapy is the manipulation of the muscles to try and reduce the local tone. The therapy is the active pulling down of the larynx to reposture it. And to me, that's certainly, it's been shown in the literature to be effective. I learned laryngeal manipulation from Jacob Lieberman, and I thought it was really brilliant work. It just didn't align well with me and my 30 years of doing manual therapy. And the way I do things is, if we're going to compare and contrast laryngeal manipulation versus my approach, the therapy in laryngeal manipulation, as I said, is the movement. The therapy in my approach is what happens when we get to end range. What happens when we get to end range and we allow the patient to experience what they're feeling. And before we even start, I remind them that here is not just for me to fix your tissues. The goal for me is to bring you closer to an experience that you can relate to. Sometimes that means bringing you into connection with your voice disorder. Sometimes that means calming it or neutralizing it in some way. But in some way, it should feel like whatever I'm doing, scratch that, whatever we're doing, it feels relevant. So my approach is a much longer hold, a sustained type of hold. And that's what I use. That's what they were referring more into that study that I just mentioned, like that. Is one better than another? No, I think that they both can be very effective. I think that it's good to have both in your pocket, because there are people who like more aggressive work. There's people who like a lot more pressure. And there's people who are really afraid of those pressures. I can recall back in 2013 when I was teaching that class in Chicago, and during one of the, part of the lecture, whatever it was, I'd mentioned that I had never received laryngeal manipulation. And during one of the breaks, a gentleman came up to me and said, I do laryngeal manipulation. Would you like me to show you what it is? And what I really wanted to say is no, I don't. But I tried to be a good sport. I laid on the table because we were using massage tables, and he kind of cranked on my larynx for a while. And I said, "Oh, that's very, yeah, that's enough. That's good," because in 30 years of doing this sort of work, I never did that aggressive work. And maybe it's me as an individual, maybe it's all the lived experiences I've had giving gentler work, but that felt really threatening to me. And I can't believe that every person that walks into speech pathologist, laryngologist, physical therapist room for laryngeal manipulation, I can't believe that everybody is ready to have their larynx cranked around in the way that I had it cranked around, in the way that I learned when I took Jacob Lieberman's course. Again, I'm not dismissing it or downplaying it. I think it's very effective and brilliant work. I just think there's more than one way to do this, especially if we're working from shared decision making, which is kind of the entire core of my model, is shared decision making, not clinician as expert. So maybe you will like more aggressive work. Maybe you prefer slower work, more gentler work. I'm willing to work within a range of possibilities versus saying, here's what we need to do to reduce that laryngeal tension.
So you really allow the patient to guide which tool or which kind of treatment that you go with. Is that
absolutely? And I'm a huge proponent of shared decision making throughout my interventions as a physical therapist, and try and promote it with the speech pathologists who take the classes, because shared decision making is making inroads in terms of the literature, et cetera, but I still think it's still pretty unknown. And I know I'm going to speak from at least the physical therapy perspective when I work with teaching physical therapists, massage therapists. And when you put up to them that maybe it's time to realize that you, as the expert, there's sort of a boundary, an endpoint to that, where your expertise ends is where the individual's expertise begins, right? Their own lived experience. No matter how much experience and training I have, I'll never know what another person is feeling until I ask them, until I include them throughout the intervention.
Mm. So I know you've kind of touched on this. Some people have asked, are there specific populations manual therapy is best suited for? And so it seems as though what you say is it's really patient dependent and kind of, or I guess, you know, are there
Yeah.
certain populations you won't use it on, or is it really if the person comes to you and you get a sense that this is something they would be open to, you kind of start with that, or how does it?
Yeah, the patients who I wouldn't use it with are probably the patients that you wouldn't treat as well without them being seen first. In New York State, physical therapists can see direct access, limited direct access. So a person can walk in my door never having been screened by somebody smarter than me, right? Somebody who has the ability to do diagnostics, et cetera. I know enough not to do manual therapy on that person until they've been properly screened. There's certainly other red flags in terms of wounds and surgery, et cetera, fractures. But for the most part, how does the person respond to touch? That's what we're looking for. Um, as a physical therapist, I get patients walking in here all the time. They said, you know what? When I went to see my doctor or went to see the normal physical therapist, because I'm sort of an abnormal force physical therapist, because I don't primarily use exercise as my only modality, right? But they'll tell me things that, you know what? That person never even touched me. And now I know the orthopedic surgeon might not have felt it necessary to touch this person's knee because they did the CAT scan, et cetera, et cetera. They figured it out from there. But the contextual value of touch for certain individuals is huge. And I think we're offered sort of an easy inroad with some people by just reaching here and giving them that sense of validation. Not only validation, but the sense of curiosity that somebody's actually using other means to try and help me figure this out. Now, granted, I am completely biased in the manual therapy direction. I'm not a speech pathologist. I'm not a voice coach. I know, superficially a little bit of what you do, but I don't pretend to know that. I know you have other wonderful interventions available to you. And when I teach manual therapy to speech pathologists and others, I tell them this should never be thought of as a standalone intervention. It should be embedded in everything that you're currently doing.
Hmm. Um,
If
I
I
think
may,
that's, oh, go ahead,
I
Walt.
just, going to that historical, that sort of timeline, that in the 90s, it was all about, I call it the what happens in Vegas stays in Vegas perspective. You've got too much muscle tension here. Let's manipulate that to reduce the muscle tone. And originally, you read some of the early papers, and they literally were talking about us having an effect at the local level. But then when you start looking at the progression of papers and studies, I use Nelson Roy as sort of my beacon for these because Nelson is published prolifically on using laryngeal manipulation. And if you start to sort of lay out all his papers and read them, as you go through the decades, you'll notice that in sort of the middle 2000s, he started to use, or he and the people who were writing with him, started to use a more multifactorial language. Instead of it being all about here, they're acknowledging, the influence of higher centers on not only the muscle tension dysphonia, but also the effects of the intervention. Until you go to 2019, when Nelson Roy published the neural bases of muscle tension dysphonia. And if you're not familiar with that paper, they had a woman with muscle tension dysphonia read a script while she was in an MRI, and they watched what parts of her brain were highlighted, were active, and they saw a pretty typical pattern of dysregulation. They pulled her out of the machine and they performed the equivalent of a session of laryngeal manipulation, laryngeal reposturing, and then the tapering, where basically while they're sort of holding the larynx down, they would have her begin to speak to see if she could form a better voice. And then if she could, they'd taper their pressures away so she could feel like she could do it independently. And once they got her to a more normalized voice, they slid her back in the MRI and they had to read the same script again. And what they saw was a very different brain activation pattern, a much more regulated brain. And that's not Nelson's conclusions were not, see, it's not here, it's here, but they were showing the complexities of possibly the problem as well as the complexities of the effects of the intervention. And there was a study 2 years earlier by Spangler that basically was along a similar lines. And to me, we can't all have an MRI pre and post treatment, right? But those are the sorts of benchmarks that we need to put ourselves to, at least in manual therapy, is to describe better what's going on. And that's my whole, the the drum I'm beating on now, is understanding that the mechanism of actions of these works are very complex. It's not just about breaking up muscle tone.
I was going to pop in for a second and ask Hillary, can I weave in some questions from the chat? I know you have
Yeah, go ahead.
questions to get through as well. You know, while you were talking about, you mentioned, you know, this is a modality in the speech pathology world. It's just one component of what would be a comprehensive treatment plan, and I think that's important
Right.
to conceptualize. We have a question in the chat though from, you know, from the voice teacher perspective. Of course, very common and appropriate, and I recommend this as both a voice teacher and a speech pathologist as well. Various kinds of stretching with voice students, basic
Mhm.
self-massage, awareness of alignment, body awareness in general. Are there basic manual therapy techniques for students to do themselves that you recommend just kind of as a matter of practice for baseline muscle tension release and self-monitoring? You know, from that patient perspective, we're talking about it's not just the issues in the tissues, but from a habilitation perspective,
Mhm.
are there things that you recommend just as a matter of practice for kind of staying in good physical health?
Let's just opt for the latter, staying in good physical health. No, we have to talk more than that, right? Because I mean, that's a huge component, whether it's diet and movement and rest and all those things. Those are huge. I don't have, so here's where again I'm going to admit my limitations. I don't work with singers on a daily basis in terms of teaching them things that they should do every day. But there's an interesting parallel that's come out in the literature in terms of athletics when it comes to stretching. All right. It used to be, if you didn't stretch, you were dooming yourself to underperform and you're guaranteed you're going to get injuries. But the latest literature says that stretching is nowhere near the thing that we thought it was. And they've gone from, the static, everybody stretch their hamstrings together, to more movement-based stretching. And so much of the current literature is saying, maybe the best way to get warmed up is to actually begin doing the activity versus things that you need to do. But yet up here in the mind of an athlete, whether it's a runner or a vocal athlete, they feel like if they don't do these things, you're going to be vulnerable. So I think sometimes we have to kind of feed into their biases a bit. You have to give them what they want. I know that I get a lot of dirty glances from people who say maybe the warm up isn't quite as important as we thought, maybe posture isn't quite as important as we thought, et cetera, et cetera. But there are certain things that I will teach my patients if they're coming in here for rehabilitative work. But it tends to align with what we did with them to help them get past the problem, things that they could do on their own. And I always, when I'm teaching the class, we always sort of transition, okay, if this is a technique you're going to do to help with this, these are things you can do with yourself. And I do hand over hand with a patient. And then I taper, just like Nelson Roy does, I taper away to see if then they can hold those stretches. It's, the cut and paste kind of world where we have to do these stretches. I think we're leaving some of that behind, but yet the ritual and the dogma of it is sometimes we still need to do that because either the coach, the therapist, or the patient feels it's necessary. I know I really did not answer your question, and I danced around that. Who asked me that question? Michelle, but I didn't mean to avoid that. I actually have a YouTube channel with a side channel of self stretches. That they're ones that basically I teach in the class, but it's also I send them home with my patients, things that they can do for their jaw, for their cheek, for the larynx, for the tongue, et cetera. So those sorts of things are at your disposal if you wanted to check those out.
That's great. And that's if we look you up on YouTube, we'll find that.
Yeah, yeah, and there's a sub channel about the self treatment. Yeah, I've got a bunch of different YouTube channels. In fact, hang on, I want to share something. Give me 5 seconds to copy and paste this here. This is if you're interested in seeing me work, that is a video that we shot. I was teaching in Taiwan a couple months ago, and they brought in a professional singer who was having some issues to be our demo, because it's always fun when we get a real patient into the classes just to be able to see how I might handle somebody kind of from start to finish. What that video is, it's a longer one. It's about 12 minutes. Unfortunately, we did not get her to sing beforehand because we were doing other things that aren't shown in that video. I relied solely on her singing afterward and then feeding back to me what, or us, to what she felt. She had a really nice response to the work. But if you're interested in seeing how I work and what that looks like, that's probably a good video for you to watch. So it's and attached to that are all the rest of the videos as well.
Can I ask a question or
Yeah.
just give a prompt to hear your thoughts? So I'm a speech pathologist, and I agree for a lot of vocal performers or even just like people with high voice demands that we work with, warm-ups I think don't need to be as extensive as some people believe that they should be. And I think sometimes the mental part gets in the way more than our actual physical abilities do. This makes me think of this book that I didn't read the whole thing. I skimmed it, about anatomy trains. And it made me think of some of the actors and singers that we work with who have like interesting characters where they have roles where they might need to be on one leg or like crouched in a position. What are your thoughts on just like things like that, like working with people who have to use their bodies in ways that aren't typical, but they're also expected to perform? I don't know.
Can you ask the question again? I'm not totally getting your question.
Yeah, no, that's fair. I didn't really ask a good one. I guess I'm just wondering, like, sometimes we work with people who have to do really funky things with their bodies, and think of this book that talked about anatomy trains and just talked about kind of the all over. So say your character has to walk on a peg leg. So should you be practicing with your leg position so that your like whole body is kind of getting used to that alignment and performing in that setting?
I think that's hugely important, but I also think it's hugely important to, if we can somehow demystify the concept of posture with our patients, or I'm sorry, with our, well, it's patients or clients, whoever that is, that, posture could be assuming that peg leg gait. Posture could be, anything you can imagine, because posture, I think, has gotten to the point where we're becoming almost posture police population, where we blame everything, at least in my physical therapy world, on poor posture. That you need to get your head up, you need to get your pelvis straight, all these things, which sometimes can be helpful, but it's also guaranteed to fail because you can't hold that posture. We have to move, we have to breathe, we get uncomfortable. I think the best way we can posture train our people when it comes to, in this case, voice, is to let them play with posture, let them play with different positions, find the posture, the position in space that they can best characterize that voice, that sound that they're trying to do, instead of us always being the person who says, no, you need to align better. I think that sets up some pretty faulty models of what the human form should look like. We were just, before we came on, we were talking about my skeleton there, and it was gifted to me. It's an actual human skeleton that a patient had given me. And what's really fascinating, I have one of the standard plastic ones out in the other room, and when you compare the two of them, they're really quite different. The plastic one is straight. Its posture is good. Everything's aligned. The ribs are all in alignment. The shoulders are aligned. But then you look at this one and you really look close, not just at the overall posture, because it's been sort of wired together. But when you really start looking at the bones, they're really quite asymmetric. The spine, the jaw, etc. And to me, somehow we've got in our minds that we need to be like this at all times, whether we're performing or whether we're just working at our computer, or somehow things are just going to go faulty. And I think those are things we need to move away from. So having fun with posture when it comes to voice, I think, would be a really, really fascinating idea to explore. The question on the keywords of the research, the name of that study was by Saratelli 2017. And if you Google that along with continuous touch, the paper will pop up. I'll just get ahead of myself. If anybody has any questions about things that I mentioned tonight, don't hesitate to reach out to me through my website, send me an email, and I can send you some papers or whatever it is, or we can chat, or you can throw spitballs through email, whatever you want to do.
Oh, well, just on that, I don't know if this is legal, but would you be comfortable with us sharing the PDF of your paper, The Mechanism of Action for Laryngeal Manual Therapies?
Hillary, it's fine with me. I'm not the publisher.
Is
Yeah, go
that,
ahead.
I don't know if that's illegal. Can we put that
I
in the
have no
chat?
idea, but you know what? Yeah, go ahead. Yeah, go ahead.
Okay, that contains a lot of the citations and resources. So if people want to look at the references, it's a great paper, and kind of you know uh, complements what you're talking about tonight, and then also has a lot of these resources and citations.
Yeah, the paper was hard for me. It just came out last month, actually, in Current Opinion in Otolaryngology and Head and Neck Surgery. It was really hard for me because I could only they only let you use 2,500 words, which for me, I'm just done with my intro at 2,500 words. So that was really challenging. There were topics in that paper that I really didn't get a chance to talk to. If I can, Hillary, can I just jump off for a second
Jump
onto
off?
something else?
Yeah.
Jump off on some, yeah, because touch-based cueing. Touch-based cueing has been really of interest, and I just didn't have enough time in that paper to be able to talk about touch-based cueing, because the vocal coach, the vocal teacher, often, when it's appropriate, when it's, informed consent, they're allowed to use touch, right? Touch-based cueing. Get your chin back, get your shoulders down. And I think a lot of voice coaches feel or have felt comfortable using those minimal forms of touch to give feedback for correction. And somehow, when we do that, we view it as the mechanism of action is awareness. You built awareness. You built realization that, oh, I could do that based on the touch. Whereas manual therapy is seen as somehow having, secret access to the issues in the tissues when we hold these stretches for a longer period of time. But the more I look at the new research that's coming out, talking about the multifactorial aspects of how manual therapy works, not just in the tissues, but from the bottom up, top down, and then you really start looking at touch-based cueing, I'm really questioning, are they really that different? Because a voice coach might say, well, I'm not legally allowed to use manual therapy. But if you're legally allowed to use touch-based cueing, it's quite possible that you might have the same effects, the same impacts as we get, even though I hold a stretch for 15 minutes. That doesn't necessarily make it better. I sometimes really question that. Like, am I holding it for 15 minutes for their sake or for my sake? I don't really know. Lovely paper, and I can't remember if it's mentioned in my paper or not, but it was done by a researcher by the last name of Bittner, Bitnar, where they were looking at GERD, upper and lower esophageal sphincter pressure measured with manometry. All right. So they had a good group of patients with GERD. They did pre-testing on upper, lower esophageal sphincter pressure. They laid the patient on the table. They gently tractioned the person's head, and they put a hand down here where they called it a thoracic stabilization. You might call it on the diaphragm. And they basically pulled on the head, pressed on the diaphragm, and then they did the technique, and then they remeasured. And upper and lower esophageal sphincter pressures normalized. And there was a lasting effect beyond just during the course of the intervention. Neat paper when it comes to GERD, right? And some of the influences of GERD. But what really frustrated me in that paper is they only held the stretches for 30 seconds. And 30 seconds to me is, I'm just getting started at 30 seconds. Why didn't they hold it longer? But then I realized maybe that's me. Maybe it's not what my patients, what another human being really needs. Maybe they just need something to key into their nervous system, to give them some empowerment, some self-control, some awareness in the area to begin to create change. And whether it's there in those GERD areas or in the areas we're talking about right here for voice.
Interesting. So really what we're talking about is kind of the potential mechanism of action, maybe giving people this brain-body connection through touch. Is that accurate?
I think it is accurate. Yeah, I think it's very accurate.
And
Yeah.
kind of giving the person a sense of competency about their own body and a sense of autonomy, even though you're the person doing the touch, allowing them to have some control. And by doing that, helping connect them into their own muscles, if that makes any sense.
It really is. And also I believe, and I'm biased. Obviously, I'm speaking towards the kind of therapy that I both do and teach, this sustained sort of input. I know that when I had laryngeal manipulation, I had no chance to participate. I was not asked for my input. I also was not given enough chance to even feel what was happening, whether they were hitting key points or not, whether it was really affecting anything that I could relate to. And I think when we use a slower touch, we give the person time to process. And I call it playing back the tape. Play back the tape. When we do this lateralization, and sure, me as the therapist might say, well, Hillary, this feels a little bit tight here on you, but what do you feel? Giving you enough time to figure out, okay, is this affecting me? Does this feel familiar? Does it feel useful? Or does it just feel like we're just pushing on something? Again, I don't want to take up too much time with the research, but there's a lovely paper that it might be in the other one by McParlin in 2022. It was in the journal Frontiers in Psychology, and they were looking at how touch is, in some ways, there's parallels with what they see with touch from some traditional concepts of mental health therapy, in that touch has the ability to connect somebody to their priors. And priors would be their past experiences. Now, I'm not going to paraphrase the whole paper, but I really like that paper, obviously, because it kind of scratches my biases, that I'm giving the person enough time to realize, is this relevant to me? Is this something that I can recognize from right now, from 5 minutes ago, or from 5 years ago? I'm giving them time to play back the tape and letting them have more input into the whole process. And see, to me, it's so much more than, the magic, the skill of the clinicians, and it's really about the skill of how we build that relationship. And if nothing else, what I'm trying to do is sort of demystify this concept of manual therapy. I got to be honest, I'm listening to a book on tape right now, and it's a Julia Child biography called Deary, and they were talking about her influence on demystifying cooking, and I thought, what a perfect metaphor that is, right? Because it's kind of what we're trying to do here is, instead of it being something that you, the speech pathologist, said, oh, we didn't learn that in school, send them to physio, they'll be able to do it, right? And certainly you can, but there's something that the physical therapist or whoever is going to be lacking. It's the context that you can provide the intervention with. And maybe a perfect world is if we all had hands on this person. But I think that the demystification of it will allow speech pathologists to see an easier path to say, okay, I didn't learn this in school, but it is within my scope of practice. We do have the potential to be impactful from our scope of practice, from our context, the way we provide this intervention.
So I guess, well, a question somebody had asked offline was like, what kind of certifications then do you need to be able to implement this? Like after hearing your talk, if a person, could a person go back and start to consider some of this in their practice, and then hopefully we'll take your course down the line. But,
Yeah.
like what are the criteria for being able to start implementing this, and who?
Well, if we're going to stick to the United States, because in other countries it's very, very different. But in the US, basically a license to touch, which I have, which you have as speech pathologist. Voice coaches, that's where it gets questionable, right? I get voice coaches coming to the class, to my classes, and I let them know that, you all have to work within your legal bounds. I do know voice coaches who's gone back and gotten, for instance, a massage certificate so that they can legally do some of this work. And a lot of people don't want to go to that extent. So, they maybe touch-based cueing is their inroad. But in terms of the training, can you feel qualified to begin touching based on this 60-minute Zoom meeting? I don't know. You got to decide that for yourself. What does your scope of practice read, right? What does adequate training entail? Some people love that concept of certification. Certification is, oh wow, it's a financial boondoggle, right? Because every year you gotta resit for the certification, all those things. I think that we're all pretty smart. We've gone through really rigorous training with some basic understandings of red flags, of basic sense of touch, basic sense of communication. This isn't exactly hard work. Maybe it's a little disingenuous for me to say that because I've been doing it for so long, but I really don't feel like it has to be a laborious process. I know a number of you have taken my introductory class, which is just 2 days, and then have gone and used it and never looked back. And some people come back and retake the class or take the advanced class, but most of the people are saying, you know what, it worked perfectly the way you taught it. Benjamin.
Hi, everyone. So I'm a laryngologist, and I'm wondering, what do you wish all laryngologists knew about manual therapy? And if we wanted to enhance our synergy with those who offer manual therapy, and perhaps if we even wanted to have some of the skills ourselves, where do you see manual therapy working best in the world of the laryngologist?
Well, I know a number of laryngologists who are actually doing various forms of manual therapy as a part of their evaluations. And I think they're using it essentially as, okay, we've got all these possibilities. What happens when we touch this person? Um, I I could see it easily fitting into your evaluation protocol. Um, there was more to the question than that, but I've forgotten the rest of it.
Well, I think you kind of hit the nail on the head. You know,
Yeah, yeah,
something that comes up for me a lot is um, we see the patient, we examine them, we perform a video stroboscopy, and if nothing is jumping out to us on the video stroboscopy, often we're left
mhm,
saying, okay, well, we'll send you to the SLP, and they're going to do their
yeah,
magic, and we're going to see what happens. And it
yeah,
feels like there's a little bit of a gap there of
yeah,
no, number one, wanting to actually having I mean, I can just speaking for myself, wanting to have a better understanding of um, who is likely to actually respond positively.
yeah.
Uh, and maybe there are things that I'm missing that can help kind of bridge that understanding a little bit between the patient who has dysphonia that you can sometimes hear very plainly, but you're just not seeing uh, something on the stroboscopy that lines up with what you're hearing.
Yeah. Um, one of the things, the first things I do with a patient is I try and get them um, not just to talk about what it sounds like to them, right? Their voice sounds like, but what does it feel like, right? That sense of the feeling of their voice issue, and it often takes them back because they're not typically asked that. What does it feel like when that voice is not acting the way you want it to? What does it feel like? Where do you feel it? Can you point to it? And I think that localization to them and gives you an inroad to say, well, what happens if we take a look at that area and help through palpation and or just through a gentle touch to see if you can start, sort of connecting in with their experience. The negative strobe is certainly a good sign, but it's frustrating. I take it for you as well as for them because it's like, well, nothing's wrong with me, but something's wrong with me. And I think sometimes I believe the touch can help sometimes bridge that gap where that sense of when they talk about that raspiness that it's so far inside that I can't even touch it, and then using some of the techniques, and I hate to be like pushing off like this, that we do when we go retrolaryngeal, that you really can almost connect with that because what we've been able to see on fees is that when we do some of these, you're having an immediate impact on the vocal folds and the entire surrounding structure. To be able to use touch as a further part of the evaluation. I don't know what that would look like because I'm not a laryngologist, but it would be really fun to sort of put that together to see what else you could do along the lines of touch.
Yeah, I'm thinking about and this is the last comment I'll make, and then I'll pass it on to someone else.
You're fine, yeah.
I'm thinking about a particular patient of mine who's a vocal performer whose chief complaint was pain with singing.
Hmm.
Within 5 to 10 minutes of starting to perform, she feels pain, but has absolutely no uh, voice change. She says her voice is as clean and clear as it always has been. It's just she
Hmm.
consistently feels pain when she sings, and scope is spotless, and you don't even really see the typical stroboscopy findings of muscle tension dysphonia, and that really leaves me uh, kind of I basically have to send her to an SLP and say, good luck, and I hope they can find something. And so
Yeah.
this is where I see for myself manual therapy really kind of bridging that gap.
Yeah, because I mean, honestly, manual therapy was certainly used for decades with more of a pain population. That's how I was introduced to it. And then moving into this population where it's not necessarily pain as the primary complaint, took some sort of, re-imaging things. But to me, it would be literally saying, well, where does it hurt? Can you touch it? Can you poke at it? Can you, in essence, connect with it? Maybe that means replicate it. Maybe that means calm it, to do something to connect with it. And that's where I would come in as the clinician to say, well, if we did some of these things in this area, does any of that sort of connect you to your pain? And if so, does the stretch feel useful for helping you maybe get rid of that pain? It's not just about the skill of me or you doing it, but it's the skill of getting them to realize that they have a role in this. Because there's so many times based on my past training where I was doing something that I knew was what needed to be done. But my patient was saying, no, that doesn't feel helpful. And that was a real set up a real dissonance. So handing it over to them, this person with pain, and say, well, when you start to sing after 5 minutes, where does it hurt? Show me, touch it, help me touch it. And that could be sort of that opening of the door that you're looking for.
Thank you.
Yeah.
Well, we have a question from Davina. She asks, how do you respond to the patients who are unsure of how they feel? Has that happened to you, and how do you deal with it?
Yeah, it's frustrating, but it's real. In my population and in the population of the SLPs who are taking the class, there's a lot of times when the patient can't communicate, right? It could be, I work with kids. We work with dementia patients. We work with stroke, whatever that might be. They're tougher, but we still need to figure out a way. Shared decision making does not mean it's always equal, right? It tends to be fluctuating. Any relationship power is fluctuating. Sometimes I have to take on the bulk of the power and I have to work from how I did in the past, which is basically, well, every time I've gotten somebody like you in the past, this has been helpful. But I still keep digging at him, poking at him, and literally saying, what do you feel right now? And there's other people who just don't want to play my game because I'm so much work when it comes to that. And there's almost like, why do you need to know so many of these? Why do you ask so many questions? Shouldn't you know what to do? And it's like, yeah, I thought I knew what to do, but then I realized that I don't know you. I don't know what you would like, your preferences, your values, which is why I'm so needy. But then you get the patient who walks in the door and you think, oh, they're going to be a perfect candidate for this, right? But they, for one reason or another, they end up not. They just don't communicate. I probably lose a lot of patients because they fire me for somebody who will act like they know what to do, and I'm willing to give them up. That's no advice for what do you do with the person who can't, but or who won't. But I keep asking, I keep digging, and I use a phrase very frequently. I will help you more if you help me help you. And I reinforce that. It incentivizes this process. They get them to understand that this is a different process, maybe than what you've gotten from a PT or massage or speech pathologist in the past, where they do what they think is best. This is a different process. And we'll get better. Sometimes I stretch the truth a little bit. We'll get better outcomes if you help me help you. I don't really have a way to measure those outcomes. So I think a little like white lie right there isn't the worst thing in the world.
So it sounds like it's for these patients that it might require training them on how to collaborate in this kind of way, and that it takes a
Absolutely,
little while.
absolutely, yeah. I pre-train them on my website.
Oh.
I've got videos. I think that's a good way if you have that option. But the first thing I do when a patient comes in is say, I'm different from the therapist you've probably seen in the past. I'm very needy. I'm, kind of self-deprecating when it comes to a lot of these. So I kind of roll into that sort of a mindset. But I let them know that the process is different. That and if they're interested in more, we'll talk about the whys. But I just talk about the shared decision making, right? Um, Most people want to know that you know what you're doing. All right. And by the way, how do I explain this to my patient? Well, start with the elevator speech, the 30-second elevator speech, right? If there's too much tension in here, will stretching help? And they go, oh, okay. So to some people, that's enough. But wait a minute, what is tension and how does stretching impact? If they want to know more, then we go into the 5-minute elevator speech, right? And if they really want to know, I tell them this is going to be boring for you, but if you really want to know, we'll talk about this because it's really, really complex. How moving the larynx from side to side or up and down can possibly have a permanent impact on your voice. That's really tough stuff. Even though even in some of the papers, even some of the papers published this year, they're still talking about the issues in the tissues that we're remediating, which is, I think, is really behind the times.
Oh, there's so many questions to ask. But I know we're kind of running close towards the end, and you had mentioned a demonstration. Would you be willing to show us a little bit what a session looks like and what shared decision making with a patient might be?
Um, Not in terms of not all of those, because what we're going to do right here is more of just a sort of a demo. Okay,
Okay,
it's not going to
perfect.
entail as much of that shared decision making piece. Go watch some of my videos if you really want that.
Okay.
The video that I sent you, by the way, when I was teaching in Taiwan, everything was translated, so there's a lot of back and forth with the translation going on too. Some of the other videos follow it a little bit more smoothly if you're looking for an all English version of this. But this is a technique that I teach in my classes, all of my classes. And if you've taken the class more than a couple of years ago, it wasn't presented quite in this way. But we use this technique, if you want to call it that, this intervention, both for issues relating to swallowing as well as somewhat with issues of voice. And in terms of the swallow, the laryngeal elevation is a lot stronger than the pitch changes of the rising in the larynx with voice. Okay, but yet there's still an elevation and a dropping of the larynx. If you would take your fingers, and if you can, I'm going to just come close to the camera here for a second. Sternal notch is right here. The top of the sternum is right here, and thyroid notch is right there. What I'm going to invite you to do is just to place two fingers in that gap between thyroid notch and sternal notch. And then the other hand is just going to rest over the top of those. What I'm going to have you do, and speech pathologists, if you're working with swallowing, you can try this with swallowing too, because it actually is really a quite kind of an interesting intervention for that. But if you were to take your fingers, and ideally you have no lotion or oil or makeup or anything that's going to have you slide, but what I want you to do is essentially just drag your skin downward. And if you feel like you're sliding a bit, go back and grab a little bit. Now, you can hear my voice affected already from that. But what I'm doing is essentially anchoring my larynx down. I'm tethering it down by taking hold of the skin, which is attached to the muscle, et cetera, all the way inward. And if we anchor the larynx down, we're in essence creating resistance to laryngeal elevation. And if I had you, let's just do the swallow first, if you will. And I'm going to warn you, if you're going to swallow, do it very gently in the beginning. Because if you've got a real good anchor there, sometimes it even hurts to swallow. But go ahead and swallow for a moment. And I'm guessing some of you felt resistance. It was being challenged. Possibly it was an aggressive stretch. Maybe in some cases it was painful. If I was doing this with a patient, I would ask them, did that connect you with your swallowing issue? And if so, does this feel like something you want me to hold? But if we think along the same lines with laryngeal excursion with voice, if you could do some anchoring like this and have the patient then go in through pitch glides or whatever it is you might use in terms of getting them to have some laryngeal excursion, what do they feel when they do that? More than just a stretch, right? Because it could be a very effective stretch or something else that we'll talk about in a moment. Does it feel like it's a difficulty you experience when you try to get to those upper ranges, right? Are we, in essence, replicating some of that voice disorder? Whether it's the pitch, whether it's the quality, et cetera, et cetera. And if so, what would happen if we would hold this stretch? Now, here's where we get into some of the interesting things to me is because traditionally manual therapy is seen as stretching something that's tight. But if you, let's go back, and I know this is a voice foundation, but let's talk about swallowing for just a moment, right? If we anchor the larynx down and then I have the patient go ahead and swallow, they're basically going against resistance, okay? My stretching could be seen as stretching tightness, but if they're working against resistance, it could also be seen as an exercise, right? In essence, a strengthening exercise. And I actually think that in a lot of ways, manual therapy stretches could be a different form of an exercise as well. Because is functional strength just a quality of building a bigger muscle? Or is functional strength when we have a stroke and they've lost, quality voice? When we get better strength, does that mean their tongue is actually stronger, or you built awareness, neural pathways, the whole thing. And this is the complexities of manual therapy that I'm talking about. When we do an anchoring of the larynx for swallowing our voice, and we use that as an intervention, and then we let go, do they have better range? Do they have better strength? Do they have better endurance? Do they have better flexibility? Those are the things we're looking for, right? And simplistically, this is my work. It's anchoring, whether it's anchoring down here, getting in behind sternocleidomastoid and behind the thyroid cartilage and exploring slowly from side to side. We're looking to connect with something that the patient can relate to. We do so much work for the tongue, and whether it's the sort of the classic tongue pulls, which is how I taught this work for years until some brand new stuff for the over the past year, where we've been combining stretching and resisted exercises for improving tongue with the neurologic or tongue movement with neurologically impaired. But definitely when it comes to voice and swallowing, some of the tongue work can be really instrumental with introducing options, introducing awareness, right? I'm really trying to demystify and move beyond that thought that it's just about getting to that exact area of tension, of tightness. We're using touch, resistance, all these things basically to build the patient's awareness, which keys in perfectly with all the interventions that you as a speech pathologist or a voice coach or possibly even the laryngologist are using.
That's fantastic. I already feel I'm excited to see how to play with that and to join your course and to learn more and explore that.
Yeah, yeah. We do a lot of different things when it comes to, well, just the whole hyolaryngeal region. That's certainly a focus of the class, as well as submental. And the tongue has really been really fascinating for me as a personal journey over the past year or two, just continuing to learn on my own, and then immediately passing it on to people who are taking the seminars. It's a lot of fun.
I have one more question unless the audience has any more. And then if there's anything else you want to add, Walt, I know you're joining us from the East Coast, so it's really generous and also getting late there, especially with this time change, things are strange.
Yeah.
Something I run into in the place where I work, I'm not always the person there during their stroboscopy or getting to actually be in the same room as the patient. I sometimes see them, after their assessment virtually, and also I think as a speech pathologist, I want them and I want to create a connection and, explore their voice, but I also want them to be able to feel like they don't need me in order to connect with their larynx or even to do these things. And I think sometimes I run into a place where they're like, can you do that? Can you do the thing? It feels just so good. And, part of me is, do you have anything like, what are your thoughts on, can a patient learn to do this on their own? Is that effective?
Absolutely.
What's the goal?
Yeah. Well, the goal is to return them to function or to help them maintain function, right?
Mm-hmm.
One of the knocks that manual therapy has gotten in the physical therapy profession, pardon me, over the past 15 years has been it's a dependency building intervention, one that in essence the patient must come to me for help, whereas exercise is viewed as somehow more righteous because you're independence building. You're teaching them exercises that they can go ahead and do. And in the traditional sense, manual therapy can be very dependency building if you're not empowering the patient to take ownership of this. And that's the one thing that I try and do immediately that's part of the whole, tell me what you feel, show me what you feel, get them involved with it and realize that they're an integral part of this. And we do a lot of training for them. In fact, sometimes I will work hand over hand with them where my hands are over them. That could be because they're a little afraid of what might happen, pain, whatever. But I actually don't mind working through their hands because as I'm working, they're basically saying, oh, I get it. I see what he's doing. Maybe I don't need to pay him all this money to come and see him. And really, that's the kind of intervention that I'm looking for. I believe that my work, and I don't care whether it's voice or foot pain or headaches, the work that we're doing within 3 sessions, something should be making a lasting positive change or do something else, right? Regression to the mean is too strong when it comes to rehabilitation to say it's going to take you 6 months for this work to work. And I think those are just end up being endless money trains for people. I definitely teach self-empowerment, self-stretching, but I also try and instill the sense of the lack of being fragile, of being robust. And I think that's one of the take homes that I want them to know is that you really don't really need me. I'm here for you. But what I want you to feel is that you have the capabilities, whether it's using your hands to help yourself or just now knowing that you're capable of change, that you can continue this on your own.
And do you think that if you're not able to be in the same room as a person, can you kind of do this virtually?
Well, before 2020, I would have said no. But right, I mean, look at all the things we've said yes to now over the past 4 years because of that. Um, I I'll be honest, I don't think it's the most optimal setting, but yet I've done a number of remote things like this with patients that they felt like it was impactful and therefore that it's a win. Absolutely. And if we can again demystify it, that it's not about the expert, it's not about the expert palpator, it's about the expert who's aware of their inner being. That's what we're looking to connect with. Pardon me. So yes, I think we can do this remotely, telehealth, etc.
If anyone else has any questions, please jump in or raise your hand or put it in the box. Otherwise, well, is there anything else that you feel is important to touch on or that you'd like for us to leave this meeting knowing or curious about?
No, and I know one of the frustrations is the criteria. How do you figure out what's the optimal patient? Because I know that question came up a couple of times and I get it a lot. And I'm going to be blunt, I don't have great answers to this one. I know that, it's possible through some really well done research to maybe narrow that down. Um, a lot of times it's used as a last resort. Okay, let's send them to somebody to do some laryngeal manipulation, which that's a possibility. But I just think that if we can begin using touch in a non-denominational way as more of a form of communication, instead of the thought that it's about fixing something. I think that sense of, well, what's the perfect patient for this? Those questions might sort of drift away a little bit.
That completely, yeah,
Yeah,
that
yeah.
makes a lot of sense.
Yeah. And like I said, if anybody has questions, don't hesitate to reach out to me, whether it's on social media or through an email. I have no problem with chatting at all in terms of questions or comments on what we've talked about.
And well, I think, if anyone has a chance to take your course, it really is transformative and volunteering for
Thank you.
you to, you demonstrate different techniques. And I volunteered, I remember, and I have chronic pain from my dance history. And the experience I had, and I can't even exactly remember where the pain was at the time, but it was such an interesting experience to connect to the pain in the way that you guided it. And it definitely had an immediate effect that I had never experienced before. And, I imagine that's what a lot of our patients feel when they engage in this type of technique. And so, I think your hands-on experience of in your class is so useful. And I know you have the people in the class work on each other, which is also really useful. And so I think having this done to you and experiencing it on your own body really helps to understand how effective and useful it can be too. So
Yeah,
just a
yeah. I
plug,
tell
take his
people when
class.
they, oh, thank you, thank you. I tell people really honestly that they come to the class thinking they're going to learn some nifty hands-on skills, which I certainly hope they do. But what I really hope that they leave with is the understanding of shared decision making and how it can be an integral part of not just manual therapy, but of all the work we do. Because I think that piece of patient empowerment is actually more impactful than the skill of the palpation and the practitioner.
Yeah, definitely so. And I think in the therapeutic literature, they talk about these common factors that it's not really the technique, it's how it's delivered and the kind of therapeutic alliance and things, which
Yeah.
tends to be what makes an effective, two people can give the same technique, but it's these kind of um,
Leah Halal's work on metatherapy, the best, just it totally encompasses what you just talked about. That, and when I was talking with her, she saw similarities in this approach with it's not the technique, it's the therapy that surrounds the technique that really becomes more impactful than those the techniques that we learn in school or we learn in a continuing ed class. how we apply it, the context in which that we enrich it in really becomes more important than the technique itself. And that really is, I think, the embodiment of this approach as well.
Yeah. Well, thank you again so much for volunteering your time and
My pleasure.
instilling us with your knowledge.
Yeah.
And your website, would you mind putting it in the chat?
Yeah, it's waltfritz.com. Pretty
Oh, there you go.
easy.